Hello, welcome to the webinar. My name is Meg Kwong. I'm the Executive Director at the Center for Connected Health Policy. And today we're here for our spring series for a Telehealth and Medicaid webinar series. Today's topic would be telehealth policy for seniors in the Medicaid program. Next slide. A few disclaimers before we get started and some housekeeping information. Any information provided in today's talk should not be regarded as legal advice. It is strictly for informational and educational purposes. Please always consult your organization's legal counsel if you are interested in a formal legal opinion. Know that neither CCHP or speakers have any relevant financial interest, arrangement, or affiliation with organizations related to commercial products or services that may be discussed in this program. Today's webinar is being recorded, and the slides and the recording of the webinar will be made publicly available a few days after the webinar on CCHP's website at cchpca.org or CCHP's YouTube channel. Additionally, closed captioning is available today. You'll see on your toolbar towards the bottom of your screen a closed captioning option. Know that your mics and cameras have been muted and closed. If you have a question for our panelists or speakers today, please use the Q&A function. The chat function should only be used for technical questions around Zoom or if you are having technical issues. We also ask that you please refrain from political statements or advertising commercial products during this webinar. Next slide. A bit of background and information about CCHP. We were established in 2009 as a program underneath the Public Health Institute as a California telehealth policy organization. An opportunity to become the federally designated National Telehealth Policy Research Center became available through a grant from HRSA in 2012. CCHP applied for that, we received it, and we've been serving in that capacity ever since. We also work with a variety of other funders and partners on the state and federal level on other telehealth or connected health projects. We act as an administrator for the National Consortium of Telehealth Research Centers. We are also a convener for the California Telehealth Policy Coalition, which is a coalition of over 100 statewide groups and organizations interested in advancing telehealth policy in the state of California. Next slide. The National Consortium of Telehealth Research Centers is made up of the 14 telehealth research centers underneath the same grant program as CCHP. There are 12 regional research centers that cover specific states and 2 national centers, one on policy, which is CCHP, and one on technology. The 12 regional research centers act as your gateway to technical assistance on telehealth. So you have a question such as, how do I get started with a telehealth program? How can I adjust my workflow in my clinic? Or questions around policy such as reimbursement or prescribing, or questions around technology such as questions about a certain platform. We advise that you reach out to your regional telehealth resource center. If they are unable to answer the question, they have 13 other telehealth resource centers to consult with, and usually somebody does have an answer. Next slide, please. CCHP began this webinar series because we noticed during COVID-19 a great deal of focus had been put on Medicare and their telehealth policies, but so many people are serviced by the Medicaid programs in the various states, and they too were working very feverishly to address COVID-19 with their telehealth policies. We've been very fortunate that the Medicaid program staff have been extremely generous with their time in providing these the information in the various webinars. And today we're fortunate to have 2 great Medicaid programs speaking about seniors and telehealth policy. The last webinar for this spring series will be on May 21st, next Friday, and it'll focus on telemental and behavioral health. But today's webinar, as I said at the top of the session, is focused on seniors. Next slide. Our speakers today are representatives from the Connecticut Department of Social Services and California Department of Healthcare Services. We'll hear first from Kate McAvoy with Connecticut. Kate is the director of the Division of Health Services at the Connecticut Department of Social Services. She has served in her role for over 7 years. Prior to her service at DSS, Kate was appointed to serve as Assistant Comptroller Policy Director for the Office of the State Comptroller, where she focused on implementing value-based initiatives in the state employee health plan. She is also the author of a legal treatise that is republished every year. Kate is a graduate of Oberlin College with a BA in Economics and English, received her law degree from the University of Connecticut, and graduated from a CHCS NGA Medicaid Leadership Institute. She has served as Vice President, President, and immediate past President of the National Association of Medicaid Directors. And I will now turn it over to Kate.
May, thank you kindly. I'm so privileged to join this discussion today. I want to thank you and the Center for your leadership in this critical area. And on behalf of my fellow Medicaid directors, I think we're thrilled to see this focus and really critical analysis of our experience over this very challenging period of the pandemic. My slides today are intended to provide a capsule of the approach that Connecticut has taken. I do want to start by immediately acknowledging that all my peers, as May acknowledged, undertook a rapid cycle development of policy direction and implementation of a vast portfolio of telehealth opportunities, really under a very compressed time schedule as the pandemic was emerging. So I don't think you will find that one state is really unique as compared to another, but this focus on older adults and people with disabilities, I think, is important because telehealth I see as having unique value for both populations. As May is acknowledging in the chat, I apologize. I have a little bit of a fuzzy connection, so I hope it will be discernible, and I'm sure you will let us know if that's not the case. May I have the next slide, please? So along with sister and brother directors across the country, as I said at the outset of the pandemic, we really rapidly faced the question of how to enable telehealth coverage. I will acknowledge there were some vanguard states that already had in place limited telehealth experience, particularly focusing on behavioral health that predated the outset of the pandemic. Connecticut, by contrast, had no applied experience, as you'll see on the slide. We were at an early stage of proposing an exceptionally modest set of coverage parameters. We had initially focused on some behavioral health group services, services for individuals who had received out-of-state surgery, but really quite a modest array that were originally intended to be use cases to inform us for potentially broadening the approach. But of course, the pandemic arose and we, along with our sister states, really confronted the reality that telehealth was a necessary enabling feature that had to be put in place as quickly as was possible. So along with other states, we did embrace a broad portfolio. As I've indicated here, we started with primary medical and behavioral health services because at the outset, that was kind of the leading edge, that we quickly and iteratively built additional features of coverage. And I will point to the kind of key descriptors of the areas in which we use telehealth as a facilitative tool a little bit later in the slides. Like many states, but not all, we elected at the outset to pay for our telehealth services at parity with in-person visits. That's definitely, I think, a threshold question in terms of the state's approach, and then also ongoing as we emerge from the formal public health emergency. I think continuity of that approach, obviously, I think we're all wrestling with that. And then I think the final feature is that in most cases, we tried to take the most comprehensive approach that authorized use of either the video conferencing or audio-only telephone. And that was as much as it was permissible under the federal law, which, as we know, the federal government through CMS really helped us with some enabling features that were facilitative of using the audio-only approach. I will say at the outset that some of the telehealth coverage that we undertook was specifically aimed at older adults and people with disabilities. And you see a couple of examples here, particularly relating to individuals who receive home and community-based services under the Medicaid funded waivers. But there was also a lot of incidental benefit from the broader based telehealth approaches that we used in many of the areas of our categories of service. And I've listed a couple of examples. The skilled therapies were very notably kind of predominant there, that while they were not exclusive to older adults and people with disabilities, again, they had a lot of incidental benefit. Next slide, please. So the way that the slides are framed are first to give a very brief primer on the Medicaid authority pathways, because that was a very significant piece of the timeliness and the procedural pathway for launching this in Medicaid, given that many of us states had very little history or expertise in doing so. I'd like to just briefly touch on the array of member supports that Connecticut put in place. Telehealth prominently features amongst those. Correspondingly, the provider supports, because we did view telehealth as having now really reciprocal benefits, although we were intending at the outset to focus on member intervention. It had obviously very significant benefit for providers. And finally, I will give you some specific examples of the telehealth approaches that we took, focusing on the lens of aging population, and give you some utilization data, as well as the sort of emerging satisfaction data that we've been able to garner. And this is a work in progress and continually will roll forward. Next slide, please. So starting with the authorities, if we can move immediately to the next slide, that would be great. Connecticut, alongside its sister states, used several of the public health related authorities to implement telehealth. And I'll just touch upon this briefly because I think it's important to have a sense of the mechanics here. First, the Public Health Emergency 1135 waiver. This is a tool, a longstanding tool that historically was conventionally used for disasters related to hurricanes or the like. This attached at the early phase of the pandemic as a major tool that states could use. CMS did a lot to facilitate state use of this, essentially producing a template and a toolkit. So we really commend our CMS folks, our partners in the federal government, for setting up a pathway for ease of use, and then also for rapid cycle review and approval. The relevant piece here is that under the 1135, many states, including Connecticut, were able to quickly modify standing requirements for our 1915C waivers, also our 1915I state plan amendments, and our self-directed programs that were intended to give flexibilities around location of service to permit virtual approaches, and then to give other flexibilities that I think supported continuity of service. So again, the 1135 major component of the authority. Next slide, please. A nice companion to that was what are called Medicaid and CHIP disaster relief state plan amendments. As many of you know, state plan amendments are a vehicle through which states can constantly update and modify essentially the contract that memorializes the agreement between states and CMS about eligibility, coverage, utilization management, rates, and the like, all the features of a given Medicaid or CHIP program. And under the state plan amendments, the disaster relief pieces, which as you see, we used a number of those over time, flexibility could be built in for coverage of telehealth, particularly focusing on those services for older adults and people with disabilities. And again, I just referenced those under the 1135. And finally, if we could go to the last slide, we also used what are called the appendices K. These are essentially specific waivers that attach to the long-term services and supports services. And here we were able to enable remote work. So the process of determining through typically in-person assessment what an older adult's needs are, and then establishing a care plan, reassessing them on a situational basis if they have a change in status, or as required on an annual basis. Again, using this tool enabled us to do that on a virtual basis. So I think all taken together, this authority is really did promote every facet. It's really looking at location of service, the mode of service, and then enabling the authorization of the payment under the Medicaid program. And essentially these authorities braid to that end. So if I may ask, could you please move ahead to the next slide? Great. So just kind of building on that kind of procedural authorization, the next two slides really just give you a snapshot of what Connecticut did to support Medicaid and CHIP members. Again, I think you'll find really important synchrony among states in these approaches. So if you could please go to the next slide. Many features around coverage, particularly with testing and treatment and vaccinations. We tried to facilitate utilization management standards to make sure that people had continuity of care, the medications they needed. But we quickly recognized, as I've prefaced, that because of the concern around infection, that it was going to be immediately necessary to set up a structure in which these primary medical, behavioral health, and other services on which people relied were going to be able to be made available virtually. As I said, we started with the primary medical and behavioral health services, but over time we expanded over about a 2-month period to encompass each of these categories of service. So you see there are implications across the age range from our youngest folks in Medicaid. Birth to 3 was an example of an intervention, obviously, for young children, but certainly also folks with disabilities, with the waiver services, our autism spectrum disorder services on a virtual basis. And finally, the pieces around the broad-based telehealth that I think has particular relevance for older adults, like the skilled therapies and our virtual mode of assessment for certain types of durable medical equipment, such as customized wheelchairs. So this kind of gives you a bellwether of the entire package of the authorities that we put in place. We could move to the next slide, please. So other features, just briefly, and this is just by way of context setting, because I think we looked at this as essentially setting in place an array of interventions that would be complementary, telehealth being a kind of foundational part of that. But we also did a considerable amount of intensive care management. We are in an unusual state in that we are fully managed fee-for-service. We're self-insured. We work with several administrative services organization partners, and those ASO partners, I think, were extremely helpful in helping to braid the telehealth approach with the virtual and in-person intensive care management supports that they were able to provide. Our medical ASO has nurse care teams on which community health workers are embedded. Our behavioral health ASO uses peer supports and wraps around hospital services. There are diverse examples here where they were really able to leap off the telehealth coverage with the supports people needed, where there were complex health profiles, and particularly people who are presenting with serious social determinant challenges, notably lack of housing security. In Connecticut, like many other states, it embarked on a massive effort to make sure people were appropriately housed through a lot of different means. And you see, again, some other kind of pieces that I think are highly typical of states around the access supports like NEMT for people who required in-person services on an ongoing basis, and then the emerging vaccine efforts, which Connecticut has really raced forward on that. I might move ahead 2 slides. I'll just briefly touch on our provider supports. As I said, with respect to the providers, if we could go one more, thank you so much. The telemedicine, like I said, we were very member focused with telehealth, but providers obviously were experiencing an unprecedented diminution in utilization of services. It presented a huge amount of challenges from a standpoint of their financial viability. Connecticut and other states really did braid resources here, really did a lot of advocacy at the federal level around the provider funding that was available under the CARES Act and wrapping around that with coronavirus relief funds. But we did see telehealth as a major means of helping to ensure some revenue to the providers on which we rely for our network. And we saw a rapid uptake. The first 2 months of the pandemic, obviously we're a building phase, but by June, we were really able to observe a steep upward climb in terms of the utilization that I think was a real boon to providers in terms of keeping them solvent. There's other pieces here in terms of how we facilitated utilization management that we hope were also facilitative. But again, trying to look at this as kind of a package of interventions. So without all that really context setting in place, let me now turn to the more specific pieces of telehealth. If we can move ahead 2 slides, that would be great. So from a standpoint of LTSS focused, long-term services and supports focused telehealth, as I mentioned at the very outset of the presentation, there were a number of the pieces that we undertook that, while available broadly to folks in our membership, really had great value for older adults. I'll point first to the skilled therapies. This did give the audiovisual conferencing capacity. And I will say a little bit of an editorial. We were hesitant at first around this. This is an example where we really had to examine the clinical literature and carefully draft our policy and our rationales around what extent of service could in fact be provided on a virtual basis. And I think we're all in agreement that there's been some great successes with telehealth, and we should build on that. But also I think this question of clinical efficacy and the equivalency to in-person supports obviously remains as we look to go forward from here. But there was good uptake of this use of therapies, and I think it was a great boon to people who rely on in-home services in particular. Then, as you see with the 1915C HCBS services, we really converted to an entirely virtual approach, waiving the longstanding face-to-face requirement that emulated the Medicare requirements, really permitting diverse services to be provided on a virtual basis. And you see a number of those listed. That's not a full inventory, but just illustrative examples. And also put in place the telephonic coverage. I think we recognize that it is impossible to regard older adults as a monolithic population. Some have a lot of technical mastery and were readily able to use the audiovisual tools. By contrast, many others did not have as much familiarity, were not as acculturated, and or had broadband or other connectivity issues that even in the small state of Connecticut represented real barriers. So the telephonic service, I think, was absolutely essential. I'm a tremendous proponent of it. I really say overall that was the case for older adults, but in particular, we were very concerned about older adults who had been experiencing homelessness. A lot of dialogue and engagement with providers of homeless services in Connecticut around developing hubs for those folks and thinking about that, and the intersection with the issuance of public program phones, the LifeLink program, in terms of minute constraints and some of those other pieces that I think are really important, either make or break propositions of whether the phone is going to really work in an effective way. Finally, we did allow virtual assessments and reassessments. We have a very comprehensive universal assessment tool that we use. I so beg your pardon, I have some allergies going on today. I'm just going to take a little sip of water. We have active spring going on in Connecticut, but the virtual assessment, you were able to really convert that to use of that tool. And again, kind of same questions about how effective that is as compared to in-person connections and being in the lived environment of the person who's involved. I think pros and cons, but many of the folks who do this work in our regions did observe that there was still a lot of opportunity to make observations about a person's situation and surface that through that process. If we may move to the next slide. Great. We also, a few more examples, we also enabled hospice agencies to offer either video conferencing or audio only services. As I mentioned, folks with autism spectrum disorder, the behavioral assessments, and in some cases, the services themselves. This was a work in progress. And I'll just point to this as something that I think was very dynamic. The assessments, I think, worked quite well. The service array, I think it was a more difficult proposition and really had to be regarded on an individualized basis about whether that was of greatest benefit to the person involved. We did kind of do a hybrid of in-person and telehealth approaches there, depending on the individual circumstances of the person. And finally, you see another example is the audiovisual approach to evaluations for customized wheelchairs. I'll have to say, when this first came across my desk, I really wasn't an initial proponent. Seemed to me, because of the specificity, the kind of individual tailoring that seemed to me to be required for each person for equipment, would be a hard proposition. So what we did is we kind of balanced this by saying that at least one of the involved professionals had to be at the home of the individual. So we, in this way, balanced. We had the value of the virtual approach, but also the person on hand to make sure that the individualized attention could be achieved. So again, just a few examples among a number in our overall portfolio. If you could kindly advance to the next slide. So I wanted to show you just a little bit about our utilization and our uptick. Unfortunately, I don't have in this slide deck the graphical representation of this that shows the tremendous steep upward curve in the early summer of 2020. Some diminution down into early fall, and then an uptick again as we experienced the second wave in Connecticut. So I think really emblemizes the experience with infection rates. But overall descriptors I wanted to point to is that over half of our population had at least one telehealth visit, and for many of our services, particularly the behavioral health services, it was typical to have multiple touches. So you saw that on a recurring basis. 2/3 of our utilization focused on the audiovisual utilization. And that was interesting to see because we weren't sure what the balance was going to be as compared to telephonic. Telephonic was about 1/3, so substantial, and certainly board bears out the importance of it as an option. We're going to continue looking at that, but we also saw really quite robust uptake from providers. And so I thought this would be useful for you to see just across categories of service. The one area that we did not embrace telehealth and have only more recently done, and this may be a significant contrast with California, which I think has been more progressive in this area, is dental. We only recently moved to a virtual assessment of an urgent oral health need, but there's been some reticence. My commissioner is a physician and had a little bit more concern from a clinical standpoint about the utility and efficacy of the virtual services for oral health. And I think there are obviously a range of opinions there, but just to say that was the one area we really did not take up services in any meaningful respect in the early phases of the pandemic. Finally, I'd just like to tell you a little bit, if we could move to the next slide, about excuse me, I'm skipping a very important slide related to the utilization data that I just provided. We have taken very seriously in Connecticut, and I know this is embraced by so many of my peers, examining all facets of the experience of trying to provide continuity of care over the course of the pandemic from the standpoint of our service to communities of color. It is critically important to keep underscoring that communities of color had disparate impacts of serious illness, complications, obviously social determinant challenges, and also death associated with the pandemic. And so examining how effective we were with the interventions, including telehealth, has been a top priority for us. As you'll see from this chart, we were able to substantiate that there has been some pretty fair equity across descriptions of race and ethnicity in Connecticut in terms of the utilization of the telehealth tools. But I think this definitely commands further attention ongoing. and really deserves a much more granular inquiry that involves not only the data, but also the kind of sharing of lived experience. And when you start to go down to that level, pieces around the telephonic coverage start to emerge as particularly important for some of the folks about whom we have the greatest concern. So maintaining that as an option, I think, is really compelling to us. And finally, I just put a little bit of information, if we can move to the next slide, in on our feedback to date. Our Medical Administrative Services Organization did a survey of the membership. We had a pretty robust response rate. I'm sorry it's not indicated here, and I can provide that separately if people are interested, but overwhelmingly positive in terms of their regard for, their experience with it. You see a high proportion say that there was nothing that they didn't like. But there were some indicators like the sort of less personal aspect of it and the connectivity issues, which I think is obviously something we're all exquisitely keyed to making sure that we are working on. Finally, the last slide really has comparable information. If we can move one more slide forward. For the provider survey that we conducted, overwhelming positive response. We also saw, some corollary benefits like reduction in missed appointments. I think for some quite evident reasons about, this being facilitated for someone not having to leave home. They did make some observations about equivalency to an in-person visit, and then broadly signaled that they would be happy and receptive to maintaining the use of telehealth following the end of the pandemic. We've also used focus groups through standing stakeholder bodies that are member-led and primarily member-composed, really to get down to the brass tacks of how this worked in a member's view. And a very, very important aspect of this is a standing member body that focuses on behavioral health. So we're going to really look to elevate as commensurately important to the data, this piece around what actually happened in practice and what people would like to see modified ongoing. But generally, I would say we really embrace this. We look to maintain a significant portion of our portfolio as the PHE is lifted. And the kind of main pieces are, continuing to look at how well are the tools working, the connectivity, and then should we continue to pay at parity? Those are kind of the main questions presented. So May, I thank you so much. I'll turn it back to you if you would like to manage any questions.
Thank you, Kate. I especially appreciated that beginning part where you did the primer on the authorities there. So thank you for that. One question that actually I had for you that I thought was really interesting was you noted actually audio only was only a third of your claims, whereas 2/3 was audio and visual, which is kind of not what we've been seeing in some of the other states. Do you have a sense of why that may be? Is it maybe just connectivity is just better in Connecticut than it is maybe in some states with larger rural regions? Or could it have been maybe a provider preference in that they prefer providing services mainly through audiovisual, or just any sense that you might have for the sort of proportion of like those numbers?
It's a great question. We too were surprised because we thought that we'd see much more predominant use of the audio only. What I will say is that we really need to learn more about this from members. This is a kind of an emerging portrait looking back. But I think we did a lot of communication through a lot of channels, especially our medical ASO. We use social media. We really put things in very accessible language in terms of what it meant to use an audiovisual option, that you could use your smartphone, that you could be on the computer, your home computer, so that people didn't feel that it had to be some special platform associated with your provider. So I think we did endeavor to democratize it in that way. But really the simple answer is I don't think we yet know. And I'll just point to one factor, and that is for many of our folks that use the publicly issued phones, the Lifelink program, those are capped in the monthly number of minutes. For several other purposes like eligibility, related calls to our department, we've exempted the use of those minutes. We were not able to do that timely for the PHE for folks using the phone. So that may have naturally chilled people's interest in using the phone if there was an audio-visual option. But again, something I'm really interested in learning about your perspective, and then kind of examining that nationally, I think is going to be essential.
Yeah, that was just a fascinating figure to me when I saw that. One other figure that I noticed, when you had the amount of claims and the amount paid out and everything, I noticed in the FQHC lines that there were claims submitted, but there wasn't paid out to FQHCs. So why was that at a zero number there for Connecticut?
So we pay on the encounter rate. So the typical norm of paying the health center, so they were paid for telehealth visits. I don't know why that's actually not depicted as a paid claim, but it's a different means of paying than it is for the other providers. So yeah, I do want to acknowledge our health centers were absolute standouts in the use of telehealth. They particularly want to recognize Community Health Center as a major health center network in Connecticut that's done a lot of national work on use of telehealth. They were absolutely at the vanguard of this, well ahead of us at the state level in terms of the motive of using it, and the opportunities not just for provider to member connection, but the peer-based learning. And so all of our health centers, I think, really did a phenomenal job, and there was a significant use of telehealth.
So we do have questions from the audience. So I'm not going to hog up all the time here. So one of them, it's from an anonymous attendee. It said, did you see originating site reimbursed under telehealth with the waiver in place? Was the medical team customer service trained on telehealth reimbursement questions? Oh, you're on mute, Kate.
Thanks so much. I appreciate that. So our policies define who is the provider for purposes of telehealth. It's hard to give a generic answer to that, but I can give you a link to a running FAQ document that memorializes all of the guidance I've talked to. So if anyone's interested in kind of plumbing that in more detail. And let me just look, the second question I apologize. Yes. Our medical, behavioral health, and dental ASOs did a lot of training on, essentially encouraging the use of telehealth. We did many provider bulletins and provider seminars on this. We tried to use kind of all available media to culture people to the fact that we're doing this. Used important messages that went out to our entire provider network, really approximate in time. People were very responsive, for sure.
Were the two-party regulations related to obtaining consent by both parties before recording calls waived during the pandemic?
So to my knowledge, we did not dictate the standards for recording of the calls. It's an interesting question, and I think I'd have to consult with our policy folks in more detail. I know that standards for that are not articulated typically in our policies. I think it was probably negotiated more on a practice level, but I'm interested in, Renee may have more to say about that also.
I know in general, I think most Medicaid programs are silent about recording, but I also know some state Medicaid programs expressly prohibit it being recorded, like a telehealth interaction. So it sounds like Connecticut is one of those that's just silent on like the specifics of that.
Yeah, it wasn't typically our posture to kind of dictate how that was transacted, but I sincerely appreciate the question, and I think it's something we have to be very conscious of, for sure.
We'll give you one more question, then we'll shift over to Renee. But did Connecticut cover telehealth for home and community-based services, and did you study that?
Yes, as I said, we authorize a number of HCBS specific services. We enabled assessments and reassessments to be done via telehealth. We also enabled, an array of the HCBS services under the waivers to be provided on a virtual basis. One of those was adult day, group day services for people with intellectual disabilities. We really try to, in many respects, recreate the opportunities for engagement and socialization that an individual might have had in a group setting, excuse me, on that telehealth basis. So yeah, there's an array of those in the slide deck, provides some more examples, as well as pointing to the provider bulletins. We also had authority under Appendix K to do that for almost all of our waivers. We have 12 waivers across a range of populations in Connecticut.
Thank you, Kate. And Kate will be back towards the end for our panel Q&A there. And Kate, you're not the only one suffering from allergies. So apologies if you see me blowing my nose. It's allergy season here in California too. So we're going to shift to our next speaker, who is Renee Malo from the California Department of Healthcare Services. Renee has been with the California Department of Healthcare Services since 1995. In the Medi-Cal program, she serves as a Deputy Director for Healthcare Benefits and Eligibility. She provides leadership for benefit and eligibility policy planning, development, implementation, and evaluation of healthcare services and delivery systems under Medi-Cal and for the Children's Health Insurance Program, the CHIP program. HCBE is comprised of 5 divisions and 1 office: benefits, eligibility, pharmacy benefits, primary and rural Indian health, dental, and the Office of Family Planning. Renee works to ensure that policies, procedures, and related activities in HCBE conform to applicable state and federal policies, statutes, and regulations. She assists the Directorate, Administration, and state legislature in determining program direction consistent with legislative intent and consults with the Director and State Medicaid Director on issues of significant policy impact involving both Medi-Cal and CHIP. Renee has played a major role in policy planning, development, and implementation on matters pertaining to healthcare reform, implementation, and coverage expansion for children and youth under Medi-Cal. And I've known Renee for a couple of years now. We've been very fortunate to have her as a partner as we navigate telehealth policy in the state of California. So I'll turn it now over to Renee.
Thank you so much, May. And it's very nice to be with you all here today. I've been kind of running around with our May revise. But with that in mind, today I'm here to talk with you all about our telehealth policies in the Medi-Cal program, and then those policies that also had an influence with our seniors that we serve in our program. So next slide, please. So just a brief overview here in terms of telehealth here in California as it relates to the Medicaid program. So prior to the public health emergency, we did have policies that were established in our program dating back to 2011. And back in 2019, we undertook an extensive review of our policies as they relate to telehealth services. And with engagement with stakeholders, we did work on revising our telehealth policy. And what we wanted to do in that revision of the policies was to really look at ways in which we could create more flexibility for our licensed providers in terms of making determinations about the appropriate modalities for telehealth to use for the populations that they serve under the Medi-Cal program. We do believe that with those changes that were made in 2019, that they did help us to prepare for the flexibilities that were then afforded to us under the public health emergency. Not that we wanted a public health emergency to help influence the use of telehealth, but we do think that it helped to set up a strong framework for us in terms of the flexibilities. So enter the public health emergency. So during this time period, and what will now continue until at least the end of this year, are several flexibilities that were implemented in our program. And a few of those that I do want to call out is that with telehealth in the Medi-Cal program, just as another point of reference, the policies that we have enacted as well as the flexibilities cover the 2 major delivery systems in the Medi-Cal program. So that would include our fee-for-service delivery system and our managed care delivery system. And when I'm speaking about managed care, it's also thinking through the delivery systems for both dental services as well as for specialty mental health services. So with the flexibilities that were afforded to us, we did expand the ability for providers to render services appropriately based upon the applicable billing code via the telehealth modality that was appropriate for them. Historically, it had not included providing telehealth services, say through our home and community-based services programs, or through what we call our local education agency and targeted case management services. Those are county-based services that either provide support to our children in school settings or for targeted case management services that are county-based to help support individuals with chronic medical conditions or that have special needs. So in those two areas, we had not historically had a lot of use of telehealth services, but given the provisions of the public health emergency and what we had to pivot to, we did open up the ability in those systems as well for the use of telehealth services. We did allow for most telehealth modalities, so looking at synchronous, asynchronous, telephonic, and then other virtual communication modalities to be used for both new and established patients. We allowed many services to also be provided via telephone only for the first time. Our prior policy was silent on telephone use and allowed it in very limited circumstances. And then we also allowed for payment parity. And this has been a topic of discussion that I'll get into a little bit later in the presentation. But we did allow for payment parity for both in-person synchronous telehealth services and for telephonic services that were provided by our providers, both including our services provided in our clinic settings, which are federally qualified health centers and our rural health centers, as well as our tribal health centers, and both the fee-for-service and the managed care delivery systems. We also waived what we call site limitations. So we had requirements prior to the public health emergency in terms of the locations of where both the providers and the beneficiaries would have to be in order to receive services provided through our clinics. Under the public health emergency, given the social distancing requirements, we waived those limitations. And then we also expanded access in terms of good faith provisions for non-public technology platforms that otherwise would not have been allowed under HIPAA requirements. So typically you would require something that was secure, that was specific for the provision of telehealth services. However, through the federal requirements, there were allowances made for those non-HIPAA type or non-public technology platforms such as Zoom, WebEx that could then be used, and that there would not be considered to be violations of HIPAA given the circumstances that we were under with the public health emergency. Next slide, please. So with telehealth services here in California, with our prior policy, we used to identify procedure codes that providers would have to use to bill based upon the modality that they were using. When we did the revision to our policy, we removed what those procedure codes had to be, and rather what we put in place were modifiers that would be identified on the claim or the encounter to then let us know if that benefit was being provided via a telehealth modality. And the modifier would then let us know that it was either a synchronous or an asynchronous modifier. And again, the telehealth visits would also include phone and video healthcare visits, and then served in both the fee-for-service and the managed care delivery systems. So in the next slide, please. What I wanted to share today was to just kind of give you all an overview of what telehealth looked like during the public health emergency. And what I do want to note in terms of looking at the next several slides, and these are some data slides that I wanted to share to just demonstrate the influence of telehealth during the public health emergency. But I do want to give a couple of caveats with the data that is being presented. One, it is preliminary data. We are still continuing to look at the visits that have occurred during the public health emergency that are telehealth. So we do, and the data that I am presenting is based upon either visits or individuals per 100,000 beneficiaries. The ages that are identified in the slides are based upon the age the individual was at the time of the visit. And then we do stratify the data by race, ethnicity, sex, and then also by delivery systems. What I'm providing you today is just the information on our telehealth visits that we have seen since the public health emergency. And again, the data is preliminary because it's lagged because we don't have a complete run out of the data. So it's point in time. And as we continue to collect this information, we will update this information to make it more current. But this slide really shows the influence of the public health emergency and the use of telehealth. As you can tell by the little blue column, that's what telehealth looked like pre the public health emergency. The purple columns show the influence of telehealth and the utilization of telehealth during the public health emergency, which we are still currently in at this time. So these are total telehealth visits that were identified in our data as of January of 2021. And again, the data is lagged. So, and this does represent all beneficiaries in the Medi-Cal program where we had claims for the provision of telehealth visits, as well as it does cover both fee-for-service and managed care delivery systems. So next slide, please. This gives you information on sex per 100,000 beneficiaries in terms of the use. So again, we see it higher utilization of telehealth visits in females versus male. Next slide, please. This gives you information on the use of telehealth based upon the age of the population. So again, looking at those 65 and above, because we're talking about seniors today. So it's about 8,100 when you're looking at it per 100,000 beneficiaries. Next slide, please. This gives you a slice of information based upon race, ethnicity. Next slide, please. And then this also is a view of looking at the location of the individuals. So most individuals in urban areas, we see the use of telehealth visits. We see, and then there's some data where it's not clearly identified where individuals are receiving, but urban followed by rural are the areas where we have seen the highest use of telehealth visits. Next slide, please. And then this is information on the delivery of telehealth visits by delivery system. So fee-for-service versus managed care. And next slide, please. So given the public health emergency and the policies that we have put out and the flexibilities that we have put out, the department has come out with recommendations on changes that we want to continue once the public health emergency has ended. I again want to reiterate that our understanding through the current administration is that the public health emergency will at least go through the end of the year. States will be given at least 60 days in advance of when the public health emergency will end. The secretary did extend the public health emergency through July. The secretary national, the Health and Human Services Agency secretary for the center, at the national level, is the one that has the authority to extend the public health emergency, but those extensions are in 90-day increments. So when we're getting close to the date in July, then another declaration of the continuation of the public health emergency would have to be executed to then extend it for another 90 days. But in looking at our pathway forward for what we're going to do post the public health emergency, We do believe that the approach that we have taken is both reasonable and balanced in terms of looking at equity and the availability of the modalities across our delivery systems while protecting the integrity of the Medi-Cal program. It's really important to us that as we're looking at this, we recognize that what we have been doing was in the state of a public health emergency. As we're moving back to a system of normalcy, if we can say it's going to be normal, we do want to make sure that at the end of the day, we are protecting the integrity of our program, but also ensuring that there's quality of services being provided to our Medi-Cal beneficiaries. And underlying all of that is that our beneficiaries would have the choice in terms of receiving services that they're entitled to in person or via a telehealth modality. We are looking to continue the use of various modalities that were in place during the public health emergency. And then we also want to ensure adherence to HIPAA privacy rules in terms of the uses and disclosures of information. Next slide, please. So post-COVID-19, we have put out recommendations in terms of what we're looking to continue. I'm going to touch on those. We do have a public policy document, and I do have the resource at the end of the presentation where you all can see the recommendations that we have identified for continuation once the public health emergency has ended. So until the end of the public health emergency, the flexibilities that are currently in place will remain in place. But what we are looking for once the public health emergency ends is that we're going to continue to allow that for all of our 1915C waivers, and those are our home and community-based services waivers that help to support individuals who have a need for services and supports who would otherwise require care in an institutional setting at either the hospital level or skilled nursing facility levels, excuse me. So we are looking at continuation of two-way interactive audiovisual telehealth. So when they're doing their waiver intakes, like their initial assessments, when they're doing work on case management or care coordination, and then ongoing reassessments, they would have an ability to undertake those activities using audiovisual telehealth, so synchronous telehealth for those individuals. We would also look at recommending allowing for store and forward and e-consults and audio-only telehealth for case management and care coordination activities. Next slide, please. We're also looking at the ability for clinic providers, our FQHCs and RHCs, the ability to establish a new patient within their designated service area. And they would have the ability to do this through synchronous telehealth and make that removal of the site limitation permanent. So today we would require the person to present in the clinic and or for the provider to be in the clinic or the beneficiary to be in the clinic. But under what we're proposing future forward is the removal of the site limitations. And again, those site limitations have been removed during the public health emergency. We're also expanding, like I said, the use of synchronous and asynchronous telehealth services in our home and community-based waiver programs and our targeted case management programs and our local education agency Medi-Cal billing option program, and then also adding the use of asynchronous telehealth and telephone services under Drug Medi-Cal, and that's the program, again, for individuals with substance use disorder services. And those are services that are offered locally through county enrolled providers or county systems that support the Medi-Cal program. We will be requiring payment parity between in-person face-to-face visits and synchronous telehealth modalities when those requirements meet the intent of the billing code. And so this would be the same for our clinic providers as well as our non-clinic providers. And the only way that the payment parity may not be in place is if between the managed care delivery system and their contracted network providers, if they had mutually agreed upon a different reimbursement rate, then that would allow for that reimbursement rate to be different than what we would otherwise require for the payment purposes. Next slide, please. We're also looking at expanding the use of clinically appropriate telephone only and other virtual communications and remote patient monitoring for established patients only. These modalities, however, would be subject to a separate fee schedule and not be billable by FQHCs. But I do have an update for you based upon what came out today and may revise with the governor's budget. So the one thing I will call out is that for telephone only services, because that has been an area where concerns have been raised, that we are looking at proposing to reimburse for telephonic only, telephone or audio only modalities, that it would be paid at 65% of the rate that would otherwise be paid to physicians for the applicable service that they render. And then we are also looking at an equivalent type payment modality for our FQHCs and RHCs. We do have to work with our federal partners in terms of this reimbursement policy for our federally qualified health centers and rural health centers. But that is something that is different than the policy that is posted that we had originally came out with, but our the updates based upon May revise will be posted shortly on our website to reflect those changes. And then, like I said, we would also provide that for reimbursements that are done with our TCM program and our LEA program. They will follow their traditional certified public expenditure cost reimbursement methodologies that are used when services are provided by applicable telehealth modalities. So in those systems, they have a different structure for how they do their reimbursements. So we would follow that reimbursement structure in those settings for those services that they're providing via telehealth modalities. Next slide, please. We did identify certain flexibilities that we are not recommending. And like I said, we are updating our policy as it relates to the telephone only modalities for our clinics, and then also looking at the reimbursement structure for the telephone only services that are outside of the clinic setting. We would not allow the use of the telephone to establish a new patient. Again, we believe in the value of that face-to-face interaction, whether it's synchronous or in person, to establish a new patient. But once that patient has been established, then the other modalities of telehealth can be leveraged and used. I've already talked about the payment parity for telephone only modalities. So we are looking at having a different payment structure for some of the other modalities for providers to bill, but it would not be at the payment parity that we're having today, given the provisions of the public health emergency. And then we will revert back to what our policies were for our tribal 638 clinics, as the federal government sets the policies for how those clinics render their services and supports. We will be engaging with our clinic partners relative to the telephone only modalities, e-consults, and other types of communication modalities in the context of an alternative payment methodology for how we reimburse them today. And those discussions have already started. The other thing I will note is that with the change that we are making with the telephone only modality and that payment structure, the department is looking at putting in place certain utilization management controls, such as looking at the frequency of face-to-face visits versus the telephone only visits, and looking at the frequency of the use of telephone only services. But we will also be engaging with subject matter experts to help further inform those policies and those criteria that we're looking at. And again, our goal here is to help ensure the quality of the services that are being provided, and that we're also protecting the program integrity of Medi-Cal against fraud, waste, and abuse. Next slide, please. So a couple of things that I do want to call out as it relates to seniors in our program and looking at some of the policies that were put in place for telehealth services. So CMS had added 144 telehealth services that will continue through the end of the public health emergency, which includes some of the services and supports that you see here on the screen. I will note that where it is appropriate with our policies, once the public health emergency is over, we will continue to leverage and use where it's appropriate the telehealth modalities across all settings in the department, for the Medi-Cal program in the provision of these services. But part of what we do look at when we're looking at our services is that there are certain Medicare requirements when you're providing services in facilities. So we have to ensure that those requirements are met and that we're not violating any of those requirements as we're administering our Medicaid program. But these were our flexibilities that we have put in place, leveraging telehealth services through the end of the public health emergency. Next slide, please. Also through our program of all-inclusive care for the elderly, these were some additional flexibilities that were put in place in terms of the ability for services to be offered either in person or via telehealth. Also through our adult day health care centers, there's the ability to provide basic telehealth services, either through telehealth or through other remote services. Some of those basic services included like the therapies that individuals could have, psychiatric or psychological services, social services, and then recreational planned social activities. When these flexibilities are used by the PACE organizations, then they would need to notify the PACE policy unit for tracking purposes. One of the challenges that we have come to recognize in our program is not through all of our programs do we have what we call modifiers to help us to identify if a particular benefit is being provided through a telehealth modality or not. And so that is an area that we're going to be working to improve upon as we go forward and continue the use of these modalities in the Medi-Cal program. Next slide, please. Through our home and community-based waivers, we did allow for certain flexibilities in terms of either licensure requirements or some of the requirements for how services had to be rendered. Because we offer a lot of our services through home and community-based waivers, we also ask for federal approval for the use of telehealth modalities in these waivers. And then we will be looking to continue with these services and supports on a go-forward basis once we're through the public health emergency. So next slide, please. Also in our assisted living waiver, we offered additional flexibilities whereby services could be provided by our care coordination agencies or home health agencies. Again, they could determine the appropriateness of the modality to use to render services for individuals that were supported by the assisted living waiver. And then also the Office of Civil Rights did exercise discretion and not impose penalties if there were any concerns regarding HIPAA rules based upon the manner in which the services were being provided. Because again, there are certain requirements in terms of the equipments equipment that is used to help protect the privacy of the individual. Next slide, please. So in terms of next steps, and as it relates to telehealth and, the flexibilities, like I shared the flexibilities that we're looking to continue, the governor's budget that did come out today, in addition to the 2 changes that I noted regarding the telephone only payment changes that we're identifying, as well as the work with our clinic partners. We also included funding for remote patient monitoring. That was one particular benefit that we did not implement during the public health emergency, but one that we do want to have as a policy in the Medi-Cal program. And that policy would be effective July 1 of this year. We're also advancing trailer bill language. And again, the trailer bill language, it has an effective date of July 1, but it would be either based upon, because at the time, not knowing when the public health emergency would end, we have an effective date of July 1 and or once the public health emergency ends. So again, we've maintained the flexibilities that we have today until the end of the public health emergency, because that's what our federal authorities allow for. So again, adding the telephone only and the remote patient monitoring, allowing our drug Medi-Cal providers to deliver all allowable services for substance use disorder services via synchronous and or telephone only modalities. We would expand and make changes with the visits for our clinic partners to include the ability to establish patients through synchronous telehealth. Our Medi-Cal managed care plans could use telehealth as a means to help meet network adequacy standards. And this would be inclusive of our county mental health plans, dental managed care plans, and drug Medi-Cal organized delivery systems, and then also revising our alternative access standards and review process for the managed care plans in meeting network adequacy. Next slide, please. We will also be submitting, applicable state plan amendments that are necessary for us to implement the changes that we are proposing. In accordance with the federal requirements, we don't necessarily have to submit state plan amendments for the use of telehealth per se, because it's just a modality. You do have to submit state plan amendments if you're looking at changing a reimbursement rate, if you're going to be paying for something that's not at the same rate that is identified in your state plan. So for instance, with the use of telephone only services, we would be submitting a state plan amendment that indicates if a provider wants to render services via the telephone only modality, then they would be paid at the 65% of the rate that we would otherwise pay them for that in-person visit. We're going to be looking to extend and continue the telehealth provisions that we were using during the public health emergency for our waiver programs. So we do have to submit the appropriate waiver applications or appendices for that. We'll also have to promulgate some regulations for specialty mental health, our targeted case management and drug Medi-Cal programs. Next slide, please. And then we'll also be working on policy guidance. So through the rest of this year, we'll be working on ensuring that we have clear policy guidance for Medi-Cal providers across our delivery systems. And that will include updating provider manuals, if we have to issue any types of letters or notices and or patient education materials, as well as making any amendments with contract language, and then also initiating stakeholder engagement. So next slide, please. So this just provides the links to the information regarding Medi-Cal and telehealth. There's a general website as well as the link to the trailer bill and fact sheet. And like I indicated, there will be an updated trailer bill language and fact sheet based upon the changes that I referenced here earlier. as well as our public proposal. There will be an update from the proposal that we had released back in February. And with that, thank you very much, and I look forward to your questions. Back to you, May.
Thank you, Renee. And it is, Renee mentioned, it was ironic that California had considerably updated their policies really just the summer before the pandemic hit, which was not planned, but was just very fortunate timing for the state. I don't think anybody predicted that, but it was like, oh, okay, there's kind of less for the state to do in response to the pandemic. Renee, you and I actually talked about this at the beginning of the pandemic, because there were changes that California did have to make, like every other state and the federal government as well. But what was sort of like a odd consequence, I think, for some folks was because of the expansion of telehealth, you had a lot of providers who were using it for the first time, didn't have to use it before. And some of them had forms that weren't updated because they hadn't had the ability to use telehealth before, so they couldn't put something down like modifier or originating. It didn't have a box for saying like they were an originating site. I know there was like one incident that you and I had talked about where somebody had encountered that for like home-based agencies. Did you encounter that at all with other providers, especially like those trying to serve seniors, like again, like home-based agencies or home health agencies or any other type of providers like that?
Yes and no. And the challenge was, believe it or not, because you could tell by the numbers in 2019, there was just not a lot of people using it. So people, one, didn't even understand our policies. So one, it was a big education for our providers about the policies for how they could identify if those services were rendered via a telehealth modality. So, and then there were some systems like with our mental health where they have to now make changes in the system. It didn't preclude them from doing the service in that way because they were still providing the service. We just didn't have a way of accurately capturing that modality for how those services were rendered. So in some instances, that information may not be our data may not be fully represented of the modalities that were used, but we didn't want to create any barriers because systems were not in place. We tried to then look at, so like for instance, with the PACE organizations where they had to report in the information. So we tried to look at ways in which we could work around it, but we certainly didn't want to preclude people from having to identify those services. Because again, we believe that there could have been a higher use previously, but people were just not, they're doing the service, they're rendering the benefit. They just were not identifying the modality or really understood the way in which to do that. So we worked with folks on that, but then where we needed to, we are working in certain areas on the systems that are needed to be updated so that people can accurately report so we can capture that information. And then leverage, billing forms where we can to say at least just indicate here so we can pick it up because they're going to still be paid. Because remember, during this public health emergency right now, we have payment parity. So we're expecting that if you're rendering the services that you're going to be paid accordingly. But the one thing I do want to caveat though is we did in our guidance, we did also indicate to our providers that you couldn't bill for something via a telehealth modality if it didn't fit. So for instance, there was an issue, and I recognize we're talking about seniors today, but just as an example with well child visits. You couldn't bill a well child visit because that visit would entail the actual examination of a child. So if there was an applicable visit, say a senior or anyone else went in for, if the provider is not able to meet the full intent of that billing code, then they couldn't bill us for that. And so again, we rely upon the providers to then tell us that, and then would of course follow up with if we found something to be remiss in that. But we had to work through those things, but we have been, to my knowledge, has not been a lot of systems that have had to self-correct, because we've had the modifier policy and all in place when we, even prior to the public health emergency, those policies were in place. It's just across those systems and how they used to bill, if they have that infrastructure in place or not. So we have been working with folks on that and making sure that our policy guidance is reflective of that.
Yeah, it's just been really incredible to see. I mean, you have Medicare, obviously large system, they did their policies, but it's been incredible to see how all the different states had to navigate and really be very flexible and nimble and quick about this. That was the most shocking thing, of like how quickly, because we all understand you guys are a large department, you handle millions, but to be able to try to move so quickly in that short period of time, because you just had to, was just incredible to see.
Right. We had issued and had flexibilities over 75.
Mhm.
We had implemented over 75, flexibilities in our program as a result of the public health emergency. And we kind of got all those things like teed up in a matter of weeks, not months, but to your point, weeks, because we didn't have an option, and we wanted to do what we could do to help meet the needs of our beneficiaries.
We have a question from the audience here. It's from an anonymous person. So I wonder, what is the percentage in California on audio only? And I think this is being spurred because you weren't here, Renee, when Kate was talking about her data. Connecticut saw 30% audio only, and then like basically 70% audio visual, which was a little bit unusual. Do you have specific numbers for California?
Not yet. We are looking at that and delving into that data, but we do not have that yet. But it is something that's on our queue to look into.
Okay. From Nicholas Curtis, oh, sorry if I'm pronouncing your name wrong. Great expansion in California. Any plans / thoughts on leveraging Project ECHO models to expand specialty and multidisciplinary access in the coming years? For example, using ILOS to support access and equity expansion using ECHO and telehealth.
I don't know that I am familiar with the ECHO. I don't know if the question, the ILOS, if that is in reference to the in lieu of services that we're proposing under CalAIM. So my apologies, I'm just not familiar with the two component parts that are being asked. If the ILOS is something different.
Yeah, I'm not sure about ILOS myself, but Project ECHO is basically the grand rounds use of technology, where you have a usually primary care provider present a case to a panel of specialists who then provide like their information. It's kind of real time sort of e-consult, instead of like the asynchronous, like directly with a provider, you have a panel, but it's usually like taking place in real time.
I see. So interesting concept. I don't know that it would be something here leveraged at the state, but we are looking at ways in which, so through one of the proposals that has come out in the governor's budget today, in terms of population health management, and looking at setting up a portal where we are collecting information about our beneficiaries. I don't know that it's akin to what the individual is asking about, but it's not something that I am seeing that we might leverage at the state. It certainly might be an opportunity at the plan level to leverage something like that, but that is not something that is on our radar at this point in time at the state, and or even if it would be something that could be leveraged, say, through clinic systems.
Yeah, just for Nicholas's benefit, in California, and definitely Medi-Cal fee-for-service, no, it's not typically been something that we've seen in California, but Renee's right. I think a couple of plans have done Project ECHO pilots on their own, not necessarily sort of like a system-wide thing that they've done with their Medi-Cal beneficiaries, but they've done pilots on it before. I've at least heard that. Okay, so we'll bring Kate back. Perfect timing, Kate, and we'll take a couple more questions from the audience here. Let's
May I
yeah,
just
yeah.
briefly intrude on your thought to say, we have I had referenced previously Community Health Center, which is a very significant network of health centers in Connecticut, has done a tremendous amount of national work convening echo forums for providers in many different disciplines. We are not reimbursing under Medicaid for this service, but I think that is a wonderful model that's emerging that has really demonstrated the utility of the, clinicians connecting on that basis. And they've really done it on a broad scale basis. So I just commend that for folks who may be interested. Community Health Center Incorporated, and they've convened folks from a lot of different states. So thank you, May, and back to you.
Oh, well, actually, you kind of opened the door there, Kate, because there's a question for you with regards to on community health centers, with regards to payment of the encounter rate for FQHCs. Curious how Connecticut is processing the G2025 requirement for FQHCs with Medicare.
Yeah, I did see that, and I apologize. I was trying to ping our policy director to see if she could answer. I understand that relates to distance site, and I just don't know the answer. I haven't discerned that at my level in terms of how that's been handled in our policy guidance. But perhaps I could follow up with May and let her know when I do have that response. And thank you for that.
Definitely, you can just send that to me, Kate, and then we can post that with like the recording of this in the PowerPoints. Renee, clarification question for you on the proposals, the DHCS proposals for telehealth policy. The proposals shift the other modalities of like audio only and remote patient monitoring essentially into like, I call it a bucket, different lane or category from like live video synchronous. And is store and forward completely shifted over to that as well? And if it is, does that sort of change the policies for community health centers who pre-pandemic were allowed to do some store and forward and receive parity payments, such as for ophthalmology and dermatology? So I guess it's two parts. First, is store and forward asynchronous shifted over to like where remote patient monitoring and like audio only will be housed if the proposal goes through? And if it is, does that change the policies for FQHCs, what they had pre-pandemic?
So all the modalities would be leveraged. So we wouldn't shift buckets. So we would still have the ability to have the synchronous, the asynchronous. So we're still looking to continue the menu of services. We did identify in the policy that depending upon the asynchronous modality, that it may be paid at a different rate. We do know that there are some services. So there were certain services that were paid at payment parity. And it was not a lot. So like our teledermatology, I think, teleophthalmology, and telepsychology, I think were paid at parity. So that will be something we will go back to make sure that we're clear, because I know that those questions have come up in the past. But there are some things that as we're taking a deeper dive and looking at this, where there may be some different reimbursement policies that we would effectuate. And again, we would make sure that that's detailed in our policies and procedures. And then where we need to go and get federal approval, because we're doing a different reimbursement rate, we would do that.
All right, we've got time for one more question, and it is for Marge Stone King for you, Kate. Did Connecticut cover telehealth for home and community-based services, and did you study that?
I thank you for the question. Yes, I think as I profiled in part of the deck, we, as did Renee, I think there was a lot of parallels, covered remote assessments and reassessments. We actually permitted many of the waiver services to be rendered on a virtual basis. And I think I previously used the example of adult day services, group day services for people with intellectual disabilities. There was a whole range, and really waived all the other otherwise applicable requirements like face-to-face requirement. And I think so there are substantial parallels with the approach that California took. And yes, we In that we are a self-insured state, we're able to very proximately track and analyze what's occurring. That's why we are able to have that degree of detail on the utilization of the telehealth services. We have a distinct dashboard for a whole array of LTSS indicators specific to the pandemic. So COVID infection rate and deaths, uptake of use of PPE and the like, but there's definitely a section that relates to the use of the virtual assessments and the virtual services. And we've been able to describe that on a trended and visual basis through that dashboard since the top of the pandemic.
Thank you, Kate. And thank you, Renee, also for your time and your great presentation. I want to thank everyone for attending today's webinar. If we can have the slides pulled up again. So thank you again, once again, to our great speakers, Kate McAvoy from the Connecticut Department of Social Services and Renee Mallow from the California Department of Healthcare Services. This was, I know, a very busy time for you both, and Renee running from the May Revise, I know what that means. So thank you for taking time out to do this. Next slide, please. So the recording of this webinar and the PowerPoints will be made available on CCHP's website a couple of days after this webinar. It's also on our YouTube channel as well, be posted there. Next slide. Our fourth and final webinar for the spring series will focus on mental and behavioral health, and we have lined up for you the Kansas, Massachusetts, and Texas Medicaid programs who will be speaking. So information on how to register for that is on CCHP's website. It'll be on May 21st, again at 11 a.m. Pacific time, 2 p.m. Eastern time is the start time, and it will go for 90 minutes again. So once again, I just wanted to say, next slide, please. Thank you to our speakers, Kate McAvoy from Connecticut and Renee Mallow from California. You guys were wonderful. Thank you also to our attendees for attending today's webinar. Thank you especially to the CCHP staff who helped pull this together. Hope everybody has a great day, a wonderful weekend, and please everyone stay safe.